has been a hot minute since I have done anything with this podcast. So for those of you who have listened to the first 8 episodes, you will find that I have undergone a significant shift in my content and in my interest and in my focus area since then. And I think that this is really just the evolution of me as a professional and as a business owner, sort of going from trying to capture a broad base of physical therapy topics into really just focusing on my passion, which is getting more physical therapists and integrated primary care teams, and really working as primary care professionals. So that's actually the launch for this new series that I'm doing. I'm going to be starting a new primary care series in this podcast where I'm interviewing a variety of different healthcare professionals and experts that work in various primary care settings. So these are physical therapists that are either co-located or have some sort of integrated model with their primary care teams and their health systems. So this is just the beginning of this new series, and I'm really excited about it. I have a whole bunch of people on the schedule, but today we're going to be talking to two awesome guys from up in the Bellin health system in Green Bay, Wisconsin. So Dr. Joe Kucksdorf has been involved in multiple professional activities related to physical therapy for the past 10 years. This includes maintaining an active patient caseload, as well as working in multiple leadership roles at Bellin Health in the area of physical therapy, ortho, and sports medicine. Currently, Joe holds the role of team leader of clinical quality at Bellin Health, helping to oversee professional development and quality initiatives that range from fellowship mentoring, guiding continuing education offerings, to data collection for research, supporting Bellin College's DSC scholarly projects. We're also going to be talking to Dr. Dan Roenz, who's also from Bellin. He's a physical therapist and clinic manager at Bellin Health. After completing the orthopedic residency at Bellin Health via Evidence in Motion, he is the operational leader responsible for physical therapy and primary care. His primary roles include optimizing the current operational and clinic processes, as well as training new therapy staff members in Bellin's team-based care model. He's also responsible for tracking metrics such as overall consult volume, utilization as a function of musculoskeletal diagnoses seen in primary care, and referrals. So we have a great conversation planned for today. And again, this is just the first in a number of episodes where I'm going to be interviewing various people working in various places, all things primary care PT. So hope you enjoy the episode and stick around for future episodes. We'll probably be releasing them every 2 to 3 weeks, is in the plan right now. So stay tuned. Okay. Hi, everybody. So I have 2 members of the Bellin Health team from up in Green Bay, Wisconsin. And I actually did a site visit out at Green Bay with Joe last year, which was, I can't even believe it. It's almost been a whole year since then. And my initial write-up of that site visit is in our blog. So if you want more information about that, you can go visit our blog. But I will have Joe and Dan just quickly introduce themselves so that you know what their roles are at Bellin Health. So Joe, why don't you go ahead and take it away?
Hi, Katie. Yeah, I've been with Bellin for 12 years, started out as a treating physical therapist, and anyways have been here a while, but my current role is team leader of quality and professional development. So I treat patients for some of my time, and then for our sports medicine orthopedic service line, help oversee different quality initiatives, as well as then oversee the professional development opportunities for our different staff. So that's what I do now.
Awesome. Thank you. And how about you, Dan?
Yeah, so my name is Dan Roenz, and I'm a practicing PT at Bellin Health as well. I've been practicing for about 4 years, and I came onto Bellin right out of school and did Bellin's orthopedic residency in partnership with Evidence in Motion. And so now I'm a practicing PT, and I'm also a clinic manager for one of our larger clinics in Green Bay. And then along with that role, one of the things I'm responsible for is kind of being the operational lead for our physical therapy and team-based care or primary care and urgent care.
Cool. Awesome. So that's basically what we're going to be talking about today, is how and why and when and what the situation is with PTs practicing in primary care in your health system. So my very first question is, what led you to get into this model? What was your why, and why did you go for this?
I'm probably best suited for that. So we, when Bellin moved towards, we call a team-based care model, all this would have been 2014 or 2015, we're really looking at redesigning, really starting with primary care and how we deliver care. And part of the emphasis there was, there's multiple factors, but one of the big emphasis is giving the physicians and the healthcare providers more time to do what they're trained to do, which is treat the patients and unload some of the other burden, documenting and entering orders and reconciliation, that kind of thing, off of them so they can treat patients. And with that then was the idea of you had to change up your staffing model a little bit and essentially add more staff to be able to do that. But then that also led to adding what we call extended care team members, which are other subspecialties, clinicians that potentially are available to provide care for a patient that's coming in for a musculoskeletal condition, in this case, like a physical therapist. So when they redesigned the model in this team-based care and they're looking at adding extended care team members, we basically said, well, maybe there's an opportunity for physical therapy to be one of those members and offer value to patients that are coming into primary care, that may be for a musculoskeletal or some other condition that's appropriate for us to help with. And so that really opened the door for us to try and see what happened with it.
Awesome. So then I guess the next question is, how did you do it? And what did you have to go through initially to get that done? What was like your very step one?
So I think the biggest step was getting buy-in, that we could add value, in terms of a primary care model. Thankfully, we had the clinic we're at actually had some providers that were very open to it and very open to trying it. So once we had kind of the providers on board having us come in and join, then it was really getting administration to give us the bandwidth and the resources to test it, to do a pilot essentially. And so that's what we did. We did a kind of a feasibility pilot, and we tested it to see, would we be used? Was there enough volume there to keep us busy? The right kind of volume that would, match our skill set. And we did it. And ultimately, it showed that there is, and the docs will use us. And so that led us to be able to expand it and move it forward from there. Awesome.
So I'm actually going to take a step back. A lot of people are interested in getting into this model. There's a lot of PT service departments in various health systems that want to do this. It's just that initial step that they are trying to figure out, trying to sort out, what do we do? How do we do this? So when you explained it, what did you do? Did you do an in-service? Did you send some emails? Like, how did you sort of break in and first educate providers and then administrators? What was your process with that?
The first part was, thankfully we had a little bit of a head start with this team-based care, this idea that they were already exposed to these extended care team members. So that helped. But then ultimately we came in and we had to explain what physical therapy does. A lot of providers have no idea how we're trained and what we can do. So kind of explaining that, but then ultimately, even more than that was showing them. So actually then basically getting them to agree that we're going to put a PT up by you, and they're going to be available, and making sure the therapists that were up there were really kind of being pushy and nosy and getting involved in the care, and over time showing the docs or the mid-level providers we were working with what we have the ability to do. And that really ultimately was what won the day. I think, you can do all the explaining in the world, but until you actually are there with them and can show them what you're capable of doing, they really don't know and don't understand. And it started off kind of slow because we're still figuring things out, but really quickly within a few months, we saw our volumes not double, but probably increased by another, 50 to 75% than they were when we initially started. And that was just from the docs figuring out how to use us and how we could work with them and what we had to offer essentially. So really it's showing them, getting the time to be up there, and then having the therapist really kind of force their way in some ways and really kind of insert themselves into the care team.
Mm-hmm. So from that initial, like you got the providers to agree to it, was there any administrative pushback from the perspective of, okay, we're going to put a PT up in primary care, but we're that means we have to cancel appointments for that PT in the regular clinic. So how did you navigate that process? And, what was some of the initial pushback, if any?
Yeah, so I was told you're not going to get FTE to do this. You're not going to get staffing to do this. So if you want to do it, figure it out. And the way we did it is, thankfully, we had a really strong team at our clinic and basically said, guys, to do this, we're all going to work overtime. We're all going to expand our capacity within the clinic so that we still are getting the capacity is not going to change in the therapy department. We're still going to have to see our patients there, but we're going to have to figure out how to get the capacity to go up, upstairs. In our case, the primary care is on the second floor, therapies on the first floor. And so how are we going to do that? And so the way we got around that is said, okay, we know we can't do that indefinitely. That's not going to work, but let's try to do it. And I believe, if I remember right, we did it for 8 weeks. We're going to try this for 8 weeks. And we didn't do it full time. What we did is we basically carved out a couple hours in the morning and a couple hours in the afternoon where the therapist was available, and they would go upstairs, and they go upstairs for an hour, come down for an hour, go back up for an hour. So they're available for these chunks of time. And then each therapist did that essentially. So we shared that duty, and we did that for 8 weeks to just see how it worked. And we learned just from doing that, I learned that it is possible and there is volume for to do that, but it's not feasible to use that model that burns therapists out. That's a lot of running around. And, thankfully our staff did it. Our administration was fine with the overtime in order to do it. They took that burden. And then once we proved that the model was sustainable and it could work, that's when then we were able to go out and get the actual resources to then hire staffing to be able to staff it then full time, where somebody was dedicated up there and it wasn't competing against our therapy capacity, that kind of thing.
That's awesome. So what kind of initial data or metrics were you collecting in that pilot period that led, administrators to be able to give you the green light on moving forward with that?
One of the biggest things was volume. Right off the bat, there has to be volume. And we had done some initial work to see what kind of musculoskeletal or PT kind of relevant volume was coming through the primary care clinic. So we had an idea, but that's always a bit of a guess because patients come in for a mixed bag sometimes and you can't really tell. Or patients come in for something like diabetes, but they have a secondary issue that never really gets brought up necessarily in a formal way. So that was a big thing, just to make sure we could keep our therapists busy while they were up there. And then the other thing was, how do the docs accept it? Do the docs like it? So we had some satisfaction and feedback surveys for them. And then same thing with patients. We captured some satisfaction and feedback surveys from patients on their experience engaging with the doc, their team, and then us in those circumstances where we were doing consultations. And then really the third piece probably that went along with it, but it was a bit anecdotal, was getting an idea of what kind of quality could we provide, what kind of cost savings potentially. And so we had a lot of individual case studies when we were there where we felt like this was a patient that got better care. Either we kept them out of formal physical therapy because we were able to get them on the front end, or we were able to direct them to orthopedics or, something, sooner, so that they had more efficient and more effective care. And kind of that combined gave us what we needed to be able to move it forward and kind of make the argument.
Awesome. That's great. And I think that those are some points that a lot of people would be interested in hearing about. Like our primary goal is to make sure that patients are taken care of. And I think that across the board, that is what is that should be everybody's goal. But we also have to recognize that healthcare is a business, and we still have to make sure that we are maintaining volume, we are keeping people productive. So all of those things just have to match up. And it sounds like y'all did a really good job of that. So
and I think that's Dan's, I think that's where Dan's at now, right? Is continuing to take that. And while I helped start this thing and go, get it going and still advise it, now it's Dan's job to continue to take that and really, I don't want to say prove it, but in some ways study it and really understand, are we really adding value? Are we really providing more efficient, effective care and get better metrics? And so Dan's really taken the torch on that and started to run with it.
Awesome. And that's exactly the kind of, hopefully the plan is to get it out there somehow into the world when all things are said and done, but we really do need more data on these types of things. So before we get to what the future looks like where Dan is headed and where you're planning on going with that, tell me a little bit more about the actual model of care. So what does an average day look like? How many PTs are actually doing it? Is it just one person? Is it rotating? Like, give me a snapshot for somebody who has no idea what your system looks like of what the day-to-day is.
Yeah, I can take this one, Katie. So, we have two, we call them our hub clinics on either side of Green Bay, and they're very similar in setup. They have a primary care, they have an urgent care office, and they have therapy. The clinic where Joe and I both practice out of, we've had, over the years, anywhere from, 6 to 9, PTs, and then the clinic on the other side has a little bit larger, probably more, 10 to a dozen or so. And the model that we've run for the vast majority of us being in team-based care and in primary care is we have a dedicated PT who staffs a shift, which is about 3.5 hours, typically once a week, sometimes twice a week. So what we'll have is someone upstairs, with our primary care providers, generally from 9 to 12:30. Then we have a break for, the lunch hour, and then someone else will go up there from 1:30 to 5. And what we've done for the most part is essentially just kind of rotate our therapists through. So everyone will have an assigned shift per week, so someone will have, I'm Monday morning, and, I'll go Monday mornings, and that way they kind of can build their traditional caseload around that. And then also the providers kind of know who to expect to be up there. So that's typically what we've done recently. We've kind of shrunk our bench and had, someone own maybe 2 or 3 shifts a week. And that's kind of been something we've been toying with.
Okay. And when you're actually up there, how does the patient get in front of you?
Yeah. So the vast majority of the time, it's the provider goes in and sees the patient and identifies that, we could be of service, and they come out, and it's typically a verbal handoff. Sometimes it's a written with a note or something like that. Sometimes it's through their nurse, but typically it's the provider coming out after they've kind of completed their exam or their visit, and they'll ask us to go in and see the patient. There's varying degrees of exams the providers will do. Sometimes it's, they're here for a physical, like Joe said, and then, oh yeah, at the end they mentioned their shoulder's been bugging them for a year. Can you go in and check them out? Sometimes they come in for low back pain, and the provider goes in and, a lot of times says, we've got someone here that can, do a really thorough assessment. Provider might be in there for only a couple minutes, and they'll come and grab us. So there's varying degrees of handoffs, but typically the provider's gone in first. We have had times where, the provider's tied up. We know the person is here for some sort of musculoskeletal complaint, and then we've gone in first and then have given the handoff to the provider.
Okay, great. So can you explain, like, how much time on average do you actually spend with these patients when you're seeing them in primary care? And is it the same type of eval that you normally would do if you were seeing them in the PT clinic? Like, how is it the same? How is it different?
Yeah, so that's where it sometimes can be hard to, when we talk about tracking productivity and things like that, it's not as well defined as a typical, PT visit. There's a lot of communication that happens, right? So, I think from the start of, you're being called on to consult with a patient, to you going in and seeing the patient, to then finishing up and then, completing the circle with the provider, I would say most consults are done within a half an hour. Some can be very simple, and, you might be with the patient for only 10 minutes. But I've had consults that I'm in the patient and, we're doing a lot of talking or educating, and it's, 25, 30 minutes. So I would say a happy medium is probably 20 to 30 minutes when all of that work is done. I would say how it differs from a traditional, PT evaluation is, one, generally speaking, the provider's just done an exam, so you can kind of, share their exam skills, if you will. So you can kind of, brainstorm with what they've done. So you may not have to repeat that. And also knowing the fact that you only have maybe 20 or 30 minutes, you do need to prioritize kind of what you feel that patient needs to get them the best care.
Yeah.
The idea is not to to necessarily deliver it there, but to help them navigate to what they need.
Right. And I think that piece is the part that a lot of people struggle with in this, especially PTs struggle with in getting to, in understanding this concept. They're like, oh, well, we can't do our evaluation in 20 to 30 minutes. And I think that a lot of people struggle with the concept of, okay, your job today is just to make sure that this patient, first of all, doesn't have any red flag signs that need to be treated urgently or emergently. Things aren't presenting in a fashion that is non-musculoskeletal in nature, like something inflammatory or an infection or something else. And educate and reassure when and if necessary. So it's more you're serving truly as in a consultant and triage based way, as opposed to we're doing our full evaluation where we establish a relationship and have this good subjective, have our good exam, and then we're actually doing treatment same day. It might be something that looks a little bit different than that. And I think that's where a lot of people or PTs tend to struggle when they think about like, oh, I can't do that in that amount of time. That's not good care. When really it's just kind of a different service. So then my question now would be, once you see these patients in primary care, of the percentage, if you could ballpark it, or if you even have some data, what percentage of patients that you see in primary care is just a one-time consult where really they might not need to see you after that, or they don't belong to PT altogether?
So yeah, I'd be ballparking, and I'd be interested to hear your thoughts, Joe. I would say percentage of total consults that are just one-time consults are probably upwards of 60% or so.
Yeah, I would agree with that. I mean, we track that, right? We track when we go in, if this is a patient that, basically we categorize them. Should they go to, are they appropriate for physical therapy, for therapy right now?
Right.
Do they need to go see an orthopedic doctor? Are they just a consultation self-management strategy, and or then kind of an other where they're going to go do something different? And definitely the biggest two we see are either they're a formal physical therapy consult or a formal physical therapy referral and then visits, or they're a consult. And definitely consult's the biggest. I think the hard part to know is a lot of those people that maybe you start with a self-management become something else, right? So they transition. So the goal is, I always approach is to keep them out of healthcare, right? I want to deliver the smallest amount of healthcare possible. And that's a paradigm shift, I think, for a lot of therapists,
Totally.
that, just like you were saying, I totally agree with what you're saying, Katie, but keeping you out of the clinic, keeping away from therapy is actually a good thing. And so a lot of what you'll do is you'll set up a consult. You'll do a consult, you'll set up a plan that involves a self-management strategy, because that's what a lot of patients want.
Yeah.
Therapy, like it or not, is expensive and takes time and money, energy for a patient to do. So we'll set up a plan and hopefully they get better with that plan. But if they don't, then we have a plan for the next steps. What's the next step? And a lot of times the next step is formal therapy. And we see we have many cases where patients get better on their own and don't need to come in. But then we find a lot of patients try on their own for a while with what we kind of set them up to do. They get part of the way there, or they don't get there, and then they end up coming in and seeing us. But the nice thing then in that case is they have a head start.
Right.
We already kind of know that they've tried some things, they've done some stuff. And in some ways that I think has some advantages as well. At the very least, we know really that they really tried to do something on their own that hopefully was, really a meaningful, attempt at self-management.
Okay. So I'm going to play devil's advocate here because this thought just crossed my mind. What about if, let's say therapy wasn't, or physical therapists were not present in primary care at all? Would you say that as a physical therapist, you're able to deliver something different and I guess more superior than say a physician or mid-level would in the same capacity? So for example, somebody comes in with low back pain and the physician, maybe they have a list of, an exercise sheet for, just general stuff. They say, continue your activity, blah, 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 blah. Do you think that therapists in general are able to offer something better at that initial visit for self-management than say physicians or mid-levels?
Absolutely. The answer is simple. Absolutely. And that's not, that just comes from us. And I think that if you had one of our physicians sitting here, They would say absolutely.
Totally.
And this comes from one of the things I say to patients when I'm working with them is exercise and the stuff we give them is therapeutic exercise. So it's kind
Right.
of like medication. There's a certain type, a certain dosage, and it
Titration,
matters
yeah.
what type and dosage you give a patient based off their condition and their presentation in how effective it's going to be. And if it's given incorrectly, it can make them a lot worse, right? We know that,
Right.
and so in terms of that training, providers don't have that training.
Yeah.
We have that training, and that's where the difference is in us being able to give them something that is hopefully dialed in and potentially then can really help them get there versus giving them just kind of a standard exercise list that may make them worse, may not do anything at all.
Totally. And so when I did my site visit at Bellin, I actually took some of the physicians and mid-levels aside and I interviewed them separately and asked them questions about how they truly felt. And I didn't disclose that I was a PT exactly, I don't think. So they kind of just felt okay to tell me. And they were all, I would say, over the top happy with that PT was there. And a lot of them described like, oh, what our office and our system was like before we had PT and what it's like after. And there was a significant difference. So totally agree with you there. I just think that when we start talking about these things and we start talking about self-management strategies and education, well, we're like, well, why can't a physician just do that? Or why can't a mid-level just do that? And it is different. Our training and our skills, especially the way that we educate and deliver information to patients. We are very specially and highly trained in that area. So yeah, okay, awesome. I think that gives everybody a reasonable understanding of like what the actual model is like. So now I want to know a little bit more about some of the challenges that you are currently facing. So this can be anything from, well, let me backtrack for a second and then I'll get to challenges. When you go in with a patient and you start, because this will lead into barriers and challenges. When you go in with a patient and you're with them for 20 to 30 minutes, what does the back end look like? What does the documentation look like? What does the billing look like? And then we'll go from there.
Yes. So the nice thing about the system that we have is the documentation is really not burdensome to our therapists. Because there are days when you're doing consults back to back to back, and it would just become another pile of documentation that would add to all of our plates. So we really just have a very basic sort of narrative summary of what our consult entails. It's very open-ended, and what that does then is that gets attached to the provider's note. So it becomes really one note. In our system, they call it like a nursing note, but it's basically visible as a part of the provider's note. And oftentimes the providers will reference our notes or will say CPT note or things like that to add some more detail to their documentation as well. Mm-hmm. As far as billing goes, for 98% of our consults, we are not billing for any of our services. So it is a free consult during that visit. Of course, the primary care and urgent care, those billing practices are the same as they would be, if we weren't there. The one instance in which we have started to bill for is when someone will come in with BPPV and we perform cannula through positioning maneuver right in the clinic there. We do bill for that CPT code, just the treatment code. Okay, so the CPT code then goes incident to the physician or the mid-level? Yes, that's the way we have done it. We're trying to find an alternative way to do that, just with the way revenue gets directed in our health system. Gotcha. Okay. So this is another huge hang up with a lot of people because different health systems everybody's doing something different. So a lot of health systems have a similar model to what y'all have, and and they are doing incident to billing. The thing that I found out, I actually had a meeting with Rick Gowenda last week, which for those who are listening who don't know who Rick Gowenda is, he has a consulting company and he's worked for, 25, 30 years, something like that with Medicare billing and compliance.
So one of the things that he had mentioned is for the clinics that are consistently, now I know that you're not billing for most of the stuff that you do, but for those that are consistently, like every patient that they see are doing incident to billing, it then becomes, because when I first heard of that, I was like, that's a great way to get to sort of, navigate the system a little bit, not make it so that it's overly cumbersome with two providers doing two separate things when you're technically in the same group. But one of the things that he mentioned was when you do incident to billing, if you do see the patient again as a PT, that technically that same provider or physician needs to be in the building or in the space, because it carries forward. Like, so if they do one CPT code, they still have to have the same documentation that Medicare would require otherwise. And then down the line, that could create a little bit of a hiccup if you were doing like follow-up care in that capacity, which, but I'm also curious about what you guys think about the sustainability of what you're currently doing, because I know that from talking to you previously, I know that there has also been some other positives that have come from this. Even though you're not billing, you are seeing, better, when you have a touch point or you're face to face with a patient in that clinic, they're actually more likely to come to PT. Whereas if it were just a physician saying like, hey, you should go to PT, a lot of patients are like, who's got time for that? Who's got money for that? Like, I don't want to do that. But establishing that connection has helped with that. So what are some of the other, well, two questions. What are some of the, do you see this model being sustainable where it's a non-revenue generating service and you just want to keep it that way because you're having other benefits, or is it not sustainable and you want to change? So we'll see what you have to say about that.
I'll start with it. I think, the part of the reason we have the support from Bellin's leadership is going to value-based contracting, right? You hear it all over healthcare, getting away from fee-for-service and going to value-based type contracting. And I think this thing potentially has is sustainable over time if it helps add to that, right? If you can show that it is improving the value of care, which improves your ability to be reimbursed because you're providing better quality, better value of care,
from
then
the
definitely
first point. Yeah.
Difficult, now because value-based contracting is still pretty new, and we're like it or not, we mostly live in a fee-for-service world still.
Right.
And so there's that challenge. But I think if we can get there, I think it has potential. But that remains to be seen what that ratio of that value-based ratio looks like, and are we worth the expense, essentially in the capacity we're being used.
Mm-hmm.
With that being said, I think some of the other things that we've talked about is, in a fee for service, our the things we bill for aren't priced at the right price points, in my opinion. And what I mean by that is, I don't, if I see somebody for 10 minutes, I don't feel like what we bill for a full therapy evaluation, which we generally schedule 30 minutes, is really justifiable. Or if they're seeing the physician and us, that you could justify. So getting to a place where we could do a fee for service type billing model,
Mm-hmm.
I think would be really, really helpful. But getting our price points so that they're more in line with the service we're providing, we quite frankly don't really have that. That just doesn't exist.
Mm-hmm.
So those are kind of some of my general thoughts, but I'm sure Dan has some thoughts as well.
Mm-hmm.
Yeah, and I think to your point, Katie, just some of the other things, in terms of sustainability, one of the challenges we're having is, Joe and I, both practicing in this model, we have seen firsthand, the impact on patients, both from, keeping them out of our doors, but also there's been plenty of patients that would have never come in to see us when they absolutely were necessary or absolutely were, appropriate, and those are the cases where we're generating revenue indirectly.
Mm-hmm.
That it's just kind of hard to prove, and that's one of the things that we're trying to work on is how do we get really good at tracking our data and demonstrating that value when we're not generating revenue, directly, but, on the back end, we know that there are plenty of cases where, patients are coming in and they're getting our services that they probably wouldn't have if they never would have gotten that touch.
Mm-hmm, definitely. So I think bottom line is it seems like at least that having this model of care has definitely improved the patient experience from the front end, regardless of whether of whether they, follow through, or, maybe you were even in a position where you're just seeing things from a different light. So you're able to catch something that that maybe a physician or another primary care provider wouldn't catch. So you're getting that patient a better experience and better outcomes right from the start. That's what it seems like. Would you agree?
Yeah, definitely.
Yeah, I would agree with that. I mean, I think from a patient perspective, I have no doubt the value they're getting when they come and see their primary care doctor and have the opportunity to see us is much, much higher. There's no doubt in my mind on that.
Okay, so then going forward into the future, what are some of the things that you want to prioritize and that you are prioritizing? What do you want to shift? What do you want to change? What are some things going forward?
Yeah, so I think, one of the things on our kind of immediate horizon that Joe and I are working at is, how do we start to track just general outcomes for patients that we see in primary care, so starting to track some of our promise measures that we use, we're starting to use down in our outpatient therapy clinic. Can we start to track those outcomes for patients that maybe never come to therapy, but that we start on that self-management plan? I think that'd be really interesting, to see kind of what happens to those patients. And one of the things that I think would be really interesting to see is how does that compare to our clinics that don't offer that service? We'd like to look into that. And then the other thing I think, for our model in particular is, we've done this for several years. We've had, kind of a core group of our therapists do it and be ingrained in it. But then, of course, with the nature of healthcare and staffing, like we've had turnover, we've had, new folks come in and do it. So one of the things that, we're working on is how do we ensure that, the product that we're offering in this is consistent and offering the same value that it was when we first started this, and I think, developing some competencies or some training platforms for our therapists that, come in and offer this service that, is unique and is not necessarily one that you get in school or at other employers or at clinicals. So that's one of the bigger challenges we're also working at.
Okay, awesome. So, heading forward then, do you see your billing model or the entry point model changing at all? Or are you pretty happy with the way that things have turned out?
There's some really big advantages of being there with the physician. Patients come in to see their doctor, right? So you're not trying to dissuade somebody. Well, you don't need to see your doctor. You need to see the therapist.
Right.
And they want to see their doctor. I mean, the reality is relationships matter. And, and so when you can come into that as a positive thing, you really get that. And the other reality is we didn't go to medical school. Doctors are good at doing the stuff we're not good at, screening for medical issues and that kind of thing. So, really that team type model, it does have value. With that being said, it costs more, right? That's the whole deal. And can you get reimbursed for it? So, I've been banging this drum for a while and it makes sense in my head. Whether or not it'll ever work, I don't know, but getting to a point where the patient can come in to see their doctor, but we see them first, right? And we do the majority of what's needed. They still get the touch with their doc, as needed, that kind of thing. But can you increase the volume the provider is able to see, which now allows you to generate the revenue that's needed because we're able to increase the amount of volume, they're able to see, that kind of thing. And in my head, it makes sense. We haven't seen it come to fruition yet, but that would be like one way to kind of get there. But that still allows for the team-based model versus just directing them one way or the other way, essentially.
Yeah, you just brought up a really good point. I have a mentorship relationship now through the primary care special interest group, and one of the things that my mentee was talking about was, the struggle. What did he say? I think I have it written down here. One of the things that he had mentioned was just this, like, well, why doesn't the patient want to see a PT first? Like, we're doctors of physical therapy. And I was like, you know what? But that patient may have been seeing their primary care physician for 30 years, and it is perfectly fine that patient prefers to see their doctor first. It's perfectly fine and acceptable, and it should be that way. But if they have access to their doctor, and then they also have access to another group of care professionals that may be better suited for their specific issue, it then becomes this this nice team, a true team-based model where, you have your physician, but you also have your therapist, you also have your behavioral health specialist, your dietitian, if and when you need it. Because there's a lot of patients that go, vast majority of patients that go in for their annual well visit are going to be okay. They're going to be healthy and they're going to be okay, and maybe not need our services, but it's really helpful to be there for if and when those patients do.
Yeah, absolutely. And I think that's the key thing. The warm handoff is huge. You know what I mean? And it really sets us up to be able to show what we can do.
Mm-hmm.
And you had brought it up, and I don't think we really, asked it, but one of the things we tracked is we attempted to do is see how many more patients would actually come to therapy if they're appropriate when we had the opportunity to see them in team-based care versus they're just referred without our consultation. They came directly from primary care. And again, that's a great number because there's a lot of kind of subjectivity in determining, whether or not they would have been referred or not, that kind of thing. But ultimately, when we just looked at overall referrals year to year from the same physician group, the same docs, we saw about a 30% increase of those that actually attended. So, even if you wash out some of the other factors, potentially, it seems like anyways, there's enough meat on the bone there that we did have an impact on that live touch with them in primary care, and that handoff led these people then to come and actually see us that maybe wouldn't have shown up otherwise. Totally.
And I think that there's something to be said, not only from the patient's experience with you, but also as you're up there and you're I'm a huge proponent of being co-located, and not being like, oh, well, go see physical therapy down the hall. If you actually have a therapist and a physician or mid-level all in one same place where they can really kind of see you in action, you're talking about your thought processes and your clinical reasoning, then the providers and when I refer to providers, physicians, mid-levels, the primary care people, what they see you do, they're like, oh, like these people really know what they're talking about. They provide value, and then they start to feel more comfortable in the services that you have to offer, and they're going to be more likely to refer and to consult. So, and that's one of the things that I have found consistently from one site to the next. Everyone that I've evaluated has noted that. So, okay, well, in just wrapping up here, are there any other thoughts, anything else that you want to share about your location, or any other parting words?
No, I mean, I think for us is, I think, Katie, it's great that you're doing this and trying to figure this out. It's such a new thing. We're very open to collaborating. We have a model, but it doesn't mean our model is the right model or the perfect model, and continue to learn about what's the best way to move this forward. Because I do think this has future, it has a future, but how it'll look might be, be different. And definitely, this continuing to learn and collaborate with others in the profession would be really advantageous on the whole, but we would welcome it as well.
Totally. Well, I encourage everybody. I'm the new education chair for the primary care SIG. So I would definitely encourage everybody who's listening to this to get involved with the primary care SIG. It's under APTA federal. I think it's $25 to join. It's like one of the cheapest, academies or sections to join. And then you can reap all of the benefits, all the free education and resources from the primary care SIG. And so final thoughts, what would you tell to somebody who was just looking into potentially implementing this model in their healthcare system? That's a loaded thing, I know.
So Joe, I would defer to Joe because he's the one that got this off the ground. But I think, in my experience, I think one of the things that Joe said is that relationships matter. And I think, you need your physician group, your provider group to be on board and bought in, and you need to be able to demonstrate the value to them. Because if you don't, I don't think you're going to get off the ground.
Awesome.
Yeah, I would agree with that. You have to get the buy-in. So you need, a physician champion, somebody that wants to see this go. And, ultimately that's part of the reason we've been so successful is because our docs have accepted us, and continued to work with us and support us with this. And without that, I totally agree with Dan. You're dead in the water. If they don't use you and bring you into their world, you're not going to see their patients, and you can't change, help anybody. So that's really a vital piece, because we have seen where we've tried in other locations where it hasn't been as open from maybe the physician and that kind of thing, and it hasn't survived. So that's really important.
Okay. So it really, this is a paradigm shift. It's a culture shift, and we have to recognize that. And, you know, if anybody's listening to this and they are trying to get this off the ground, sometimes it might take a little bit of time to maybe see some turnover or try in a different location. There's a lot of culture shift that takes place here, and some people are more comfortable with that than others. So appreciate that fact, because it is essential to be diplomatic in this process along the way. Well, thank you guys so much for coming on this episode. I really appreciate it. And I'm so proud of you for everything that you're doing up there. It's a great model to get started in. And I really think it's going to be a game changer for our profession. So thanks so much, and have a good one.